welcome all. We're going to talk about juvenile idiopathic arthritis, and actually, it is the most common cause of arthritis in childhood. The etiology behind it is unknown, but it belongs to the family named as a rheumatic disease or connective tissue disease, or even named as a collagen vascular diseases, which characterized by autoimmunity and inflammation. So the most common underlying manifestations of juvenile idiopathic arthritis is the chronic synovitis. The disease is actually not uncommon. Okay, so the incidence is around 1 every 1,000 children. Have two big incidences. The first one is during the first and third year of life, and the second during the 8 to 12 years of life. But actually, you can face it at any age. Like other autoimmune diseases, the juvenile idiopathic arthritis is more common in female. And the juvenile idiopathic arthritis is a common name, have a subtypes. The most common subtype of the juvenile idiopathic arthritis is oligoarticular form. And in this form, especially the female is more than the male. And we have a subtype, it's called the encephalitis-induced juvenile idiopathic arthritis or ankylosing spondylitis. In this form, the male is affected more than the female. So here, talk about the clinical representation. The clinical representation actually would depend on the subtypes of the juvenile idiopathic arthritis disease. We have the oligoarthritis from its name oligo. So only 3 to 4 joints involved, not more than 5, up to 4 joints. And it affects the medium to large joint, and the most common joint affected, it is the knee joint. The other subtype is called the extended oligoarthritis, and actually it is start as oligoarthritis, and after the 6 months it extends to involve more than 4 joints, up to 5 or more. So it's called extended oligoarthritis. The other subtypes is polyarthritis. It involves 5 or more joints, okay, and could be small or large joint. It's of either rheumatoid factor negative or positives. And when it's positive, it is equivalent to that we know already in adult, the rheumatoid arthritis, okay? The other subtypes is psoriatic arthritis, and in this cases it have a relation with psoriasis in the same patient, or there is a history of psoriasis in the first degree of the affected patient. The other type is systemic onset arthritis. From its name, the systemic onset is start of fever and rash, okay? And then later on, the arthritis will develop. The enthesitis-related arthritis, okay, this is affects male more than the female, and it is of specific genotypes, or it's related with a human leukocyte anti-GB27. Okay, it have types like ankylosing spondylitis, juvenile ankylosing spondylitis, psoriatic form, reactive form of arthritis, and other, and with a relation with inflammatory bowel diseases. And other chronic arthritis is include the arthritis in Down syndrome and in relation with inflammatory bowel syndrome and other chromosomal abnormalities. So this is the subtype, just have an idea about them. This table, actually I just will comment on a specific point, that is the female is more commonly affected than male, and exception is here in the enthesitis related juvenile idiopathic arthritis. Okay, the male here is more than female. The other things, the eye involvements in form of uveitis is more commonly occur with oligoarticular form, okay? And the iritis, not uveitis, it's occur with ankylosing spondylitis. And the antibody positivity for antinuclear antibody, it's more in oligoarticular form, and the excellent prognosis mainly go with oligoarticular, which is the most common subtype of juvenile idiopathic arthritis. Okay. He say here, although the onset of arthritis is slow, the acute joint swelling is often not acutely by the child or parent such after an accident or fall and can be confused with a trauma. يعني إنه we have arthritis, and the arthritis is associated with joint swelling, but the family of the patient not notes this swelling till after an accident and a trauma. They note this swelling and they confuse this swelling with the INE may be caused by the trauma itself, but actually the traumatic effusions in children is rare. So even there is a history of trauma, the joint effusion يعني إنه don't exclude the possibility of juvenile idiopathic arthritis even if there is a history of trauma. So children often develop a pain, stiffness in the joint because of a process of inflammations. There is stiffness, yes, but actually it's not so severe that it interferes with the walking. There is also morning stiffness because, as you know, it is an inflammatory cause of arthritis, so increase in period of inactivity. Talking about the examination, here we have a signs of an inflammation in the joint that is involved. You see a swelling, tenderness by palpation, warm skins, and see the redness with effusion. Okay, the range of motion is limited due to the swelling itself or due to the presence of the pain, or a long time there will be contractures due to the disuse of the affected joint. Okay, in children the joint is enclosed to a growth plate. Okay, so it may affect it and lead to bone abnormalities in the bone near the affected joint and lead to growth disturbance. This is a picture shows the left knee show and a swelling. Okay, when the growth plate is affected and there is a growth disturbance, maybe lead to discrepancies in length between the both limbs, so there will be asymmetry. Okay, there is also associations with eye inflammation in form of uveitis or iridocyclitis. Actually, you have to understand the incidence of this involvement of the eyes increase when there is a positive ANA antibodies, when there is a human leukocyte antigen DR5, 6, or 8 positives, when the gender is a female, okay, or when the subtype is oligoarticular form, as we mentioned previously in the table. So this is the 4 things is increase the risk of eye involvements. Unfortunately, it's maybe asymptomatics, and the patient not this problem until the blindness is occur. So your job is to do a regular ophthalmological screenings by using a slit lamp examination to identify any anterior chamber inflammation. So it's merely anterior chamber inflammation, and here we have an exception that in ankylosing spondylitis the inflammation is mainly occurred in the posterior chamber. Okay, so here just a sum note about each subtype of juvenile idiopathic arthritis, and we start with the most common type, which is the oligoarticular form. Okay, it is involve the joint, usually medium to large joints, and it's involve up to 4 joints, no 5 or more, during period of 6 months because to differentiate it from extended oligoarticular form. Okay, the peak of incidence in during the first 3 years of life. The most common joint involved is the knee, and in the 75% there is a temporomandibular joint involvement. This oligoarticular form occurs without a systemic inflammation. The patient will not suffer from fever, weight loss, failure to thrive, and even the lab investigation usually it's normal. And this is in يعني بالعكس مع البوليارتيكولار form or juvenile idiopathic arthritis. This form polyarticular form it's involve 5 or more joints in the period of the 6 months. Okay, and usually a small to large joint. Okay, even the cervical spine could be affected. The patient here instead of or in comparison with the oligoarticular form, the systemic arthritis occurs. So the patient may have a low grade fever, may have a failure to thrive, anemia. Okay, a lab investigation show an elevated marker of inflammation like ESR and C-reactive proteins, and could occur at any age. In the oligoarticular form, we see mainly the presentation occur during the from the first to 3 years of life. And polyarticular could be rheumatoid factor positive or could be rheumatoid factor negative. Systemic onset juvenile idiopathic arthritis, which is also named the Still disease. You have to understand it. It is start as fever and rash and systemic symptoms, and this fever is spiky in type and occur as 1 to 2 a time. Okay, and the rash it is pink in color, like a salmon, so it's called salmon colored rash, mulberry-form rash. This rash occurs at the time of fever when it's spiky, and when the fever subsides, the rash also subsides. So this relation between the fever and the rash is important to give you in your mind the systemic onset juvenile idiopathic arthritis. And later on, there will be articular joint or arthritis that could be usually small joint, extensive resistance to a treatment. When these arthritis occur, actually 6 weeks to 6 months after the onset of systemic symptoms, internal organ could be involved. Okay, even there is hepatosplenomegaly in 70%. Inflammatory markers and lab abnormality in this case will occur. So this is the morbilliform colored, salmon colored brush, and its appearance and subside in relation to the spiky fever. Here talking about enthesitis related arthritis. It affects the axial skeleton, which is the spine, but actually it's usually start at the sacroiliac joint, and at enthesitis, which is the insertion of ligament to the bone, peripheral joints, and later on it affects the spine and cause a pumpus spine. Okay, it's include the ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and arthritis of inflammatory bowel disease. When there is no any specific finding, it's called an undifferentiated juvenile arthritis. So you cannot diagnose this form until the specific things that are related to arthritis is occur, like when you see the by X-ray the sacroiliac joint is involved, when you see or diagnose the inflammatory bowel disease, when the psoriasis is diagnosed. Okay, but the characteristic here is the HLA-B27 is positive, and they are not usually response to methotrexate or the modifying disease modifying anti-rheumatic drugs like methotrexate. not respond to usual treatment. It needs usually to start early with the tumor necrotic factor blocker. In this table, I just want to comment that HLA B27 positives with in the site enthesitis or ankylosing spondylitis here, and the posterior chamber it's involved in psoriatic arthritis. Here talking about the laboratory and imaging studies. The diagnosis is made by history and examination, and maybe you seen after that investigations that involve as simple as CBC, and it's important actually to differentiate it or to exclude leukemia, because the child is admitted to you with a lung fever and with an bone or joint pain, and this is an unusual presentation of leukemia. Okay, so and actually some of subtypes of juvenile idiopathic arthritis like oligo arthritis, the laboratory investigation is normal, show no any abnormality, and there is no systemic features. Because it is autoimmune diseases, so we sent for antibodies like antinuclear antibodies. And in case of polyarticular arthritis, we send for rheumatoid factors and ACCB antibodies to differentiate when it's positive or negative. Actually, when there is acute onset of mononuclear monoarticular symptoms, so you have acute swelling in just a one joint, monoarticular symptoms, it's maybe confused with septic arthritis. So in here situation, you have to do erythrocentesis and take aspiration from these effusions. In the separative form of arthritis and not the septic form, the usual white blood cell count is from 50,000 to 100,000, and the measles is a lymphocyte rather than a neutrophil, while in the septic one, the cell count is more than 100,000 cells per millimeter. Okay, and here its type is neutrophil rather than the lymphocyte, and maybe sent for its culture, and in the support type it will be negative. The X-ray actually it's normal at the beginning. Differential diagnosis you have to put in mind that is don't say a juvenile idiopathic arthritis till the arthritis is last longer than 6 weeks. Okay, this is very important. The treatment of juvenile idiopathic arthritis actually it is the suppression of the inflammation and to improve the function of the joint to prevent the deformity and the blindness. So the first choice is the non-steroidal anti-inflammatory drugs like in form of naproxen, indomethacin, ibuprofen, okay, and the corticosteroid it usually not used, and when it's used in some cases like in severe systemic manifestation, when there is a functional disability, so the child cannot walk, when there is internal organ involvement like hepatosplenomegaly, in systemic onset juvenile idiopathic arthritis, we use a steroid, but it's a temporary. It is called a bridging therapy, okay? Until other medications have been take effect. So when establishing the corticosteroid, you have to establish with other medications like methotrexate, which is a drug of choice for polyarticular and systemic juvenile idiopathic arthritis, and even when oligo arthritis that is resistant to usual standard therapy, which is non-steroidal anti-inflammatory drug. So in oligo that is resistant, systemic, and polyarticular arthritis, the drug of choice here is methotrexate. It have a side effects like bone marrow suppressions and hepatotoxicity, Don't forget to give it alternatively with folic acid. Biological agents, we have the infliximab and other agents like adalimumab. Here it is superior to methotrexate and it used with SA spondyloarthropathies groups, HLP27 positives. We have an interleukin 1 receptor antagonist like we have anakinra. It is a very painful in treatment of systemic juvenile idiopathic arthritis, which have also internal organ manifestations. The complications is loss of the function of the joint, blindness when there's eye involvement, and the very serious one is a macrophage activation syndrome. It is mainly occur with a systemic juvenile idiopathic arthritis, and it's caused by activation and proliferations of T lymphocyte and macrophages. So the patient will develop high fever, hepatosplenomegaly, lymphadenopathy, bleeding tendency, even DIC. The investigation showed pancytopenia and the cause behind that because this is mature macrophage will phagocytes the blood forming cells inside the bone marrow. So the bone marrow sampling, if you take, it will show you a macrophage displaying hemophagocytic activity. The IC may be a GORD, so you have a low level of fibrinogen, increased level of D-dimer, and liver enzyme also elevated. Okay, and ferritin elevated, even triglyceride. It's led to multi-system organ failure. So it is a serious complication. The prognosis is really excellent. The oligo arthritis form have no systemic manifestation. The child did well. The polyform, it is have a systemic manifestation, so there is maybe even a functional disability. And we say that we use steroid in these conditions till the effects of other drugs will be occur. Here in systemic disease, what are the poor prognosis in juvenile idiopathic arthritis? Actually, when we have a systemic disease, when the rheumatic factor is positive or ACCP antibodies positive, when there is poor response to therapy, or when the X-ray will show you a bone erosion. Don't forget the physical and occupational therapy is important also beside the medical therapy. And thank you for listening.